allows me to gaze into the eyes of the child and see the future. The diagnosis allows me to understand and appreciate risk. And if I overdiagnose, then it makes the condition seem too broad, and it waters down perhaps the true problems these children have. And if I underdiagnose, now I only have the worst children. I only have those children who at 3 years of age get the keys to the car and back the car out of the driveway. And that's a select group, but that would be a group with much more severe problems or impairment. So the clinicians want to know how to make the diagnosis. How many people are physiotherapists or speech pathologists? How many people, and language and motor problems are characteristic of, I've got this, language and motor problems are characteristic of children who have trouble developing self-control. And language is the window into the mind. Language allows me to understand you, and you to appreciate and understand me. So it isn't surprising that children with delays in language, communication, both semantics, the meaning of language, or pragmatics, the social language, using language to communicate with others, it isn't surprising that children with these language disorders often display symptoms of ADHD. And it isn't surprising that children receiving diagnoses of ADHD often have language problems that exceed or are beyond what is presented in the general population. And those of you that are physiotherapists are well aware that children who are, in the old term, hyperactive, have a much higher rate of motor problems. They're often clumsy and awkward. They have trouble with handwriting. Their fine motor skills aren't as good. And the question is whether that is a symptom of their condition, whether that is a second problem, or in fact whether their failure to pay attention leads them to have poor motor skills. As an amateur physiotherapist, I have what I call Goldstein's test. I take typically a $1 bill and I put it on the table in front of the child, and I ask the child to write his name as carefully as he can. And if it's careful enough, I will give him the $1. And what I'm looking for is the difference between how he or she writes the name just when they do it versus how they do it when there's some money to be paid. And the child with true motor problems, no matter how much money you offer, they still struggle to write their name. And the child whose problems are the result of rushing and impulsivity, well, they take more time. So we learn our first important lesson, that children with this kind of a problem know what to do, but don't always do what they know. Does everybody have that? That it's not a problem of not knowing or not being able to do, as with a child who has a reading disorder or a motor problem. This is a problem of knowing but not doing. So it is different from the child with autism who doesn't know how to socialize, who doesn't know how to deal with events in everyday life. These children, and we will talk about the relationship of autism to ADHD, and if some of you came to the conference last year, you're aware of that. How many people came to the last year's conference? Or anybody? So, okay, so you heard me talk about our research, which is finally being published this month, on the relationship between autism and attention problems, which are typically characteristic for all autistic children. So I have an idea of most of you. There are some of you who have yet to raise your hands. The only group I can think of that remains are parents. How many people are here primarily as parents of children with developmental problems? So who didn't raise their hand? What is your background, your job?
Parent, and I'm psychotherapist.
Psychotherapist.
Yeah.
Ah, okay, so I considered you under the diagnostician. So how many people are psychotherapists or counselors? So we have some. So we have a very diverse group, which means that every one of you will leave today unhappy. Because each of you would prefer that I spent the day focusing on that particular interest, and I can't do that, although I answer all my email. And if you email me, if your question isn't answered today, I will certainly make an effort to do that, typically in English. But I have access to Romanian translation. If you write to me in Romanian, I will have it translated, and then I will attempt to answer it in Romanian. Okay, so now we begin. And what I told Alistair yesterday is one of my interests as I speak around the world is helping the countries that I come to avoid 25 years of many of the mistakes that we have made in the United States. So I'm going to start today not with a discussion of autism or ADHD, but with a discussion of impairment. Impairment is the functional limitation you have because of a condition. If I couldn't walk, my impairment would be I might not be able to access certain places. And we now understand that it is not symptoms, that it is not diagnoses that are the true targets of our evaluation and treatment. It is impairment. In other words, it doesn't matter to me how many symptoms you have if you are able to negotiate everyday life as a child, on the playground, at the dinner table, in school. If you are able to negotiate those activities and do them successfully, it doesn't really matter to me what symptoms you have. Now, some of you may argue, well, wait a minute, how is it possible to have symptoms but not impairment? And I will explain that. But there are people among us, even in this room today, who are suffering from depression, for example, or have anxiety, or have phobias. You know the term phobia, afraid of something, to get in an elevator, or afraid of a spider. And yet, you sit here today and you function. There are plenty of people who have symptoms. There are plenty of people who have psychiatric conditions who manage to live reasonably unimpaired lives. So the real target is reducing impairment. Not getting rid of your symptoms, not getting rid of the diagnosis, but improving the daily quality of life as a child with impairment, regardless of the diagnosis. The diagnosis almost becomes a moot point. You have that word in Romanian? Moot, unimportant point. Okay? Becomes an unimportant point. The true target is helping these children function better in everyday life, and that's what we will talk about. I have far too much information today for the time that we have, and I may move through some things a little quicker than others. But let's start by thinking about a child. So I want each of you to think about a child you work with as an educator, as a therapist, that you live with and love, as a parent. And I have a hypothetical child. And this child is graduating from preschool. Do children attend preschool before they go to kindergarten? And then they go to kindergarten? Okay.
No, kindergarten.
The kindergarten?
It's kindergarten, yes.
Okay.
Up to 6.
In the United States, preschool has become a requirement. It's no longer a luxury. If you don't go to preschool, something is wrong with your parents. And now they have preschool. When you're 2, you go with your mother to preschool, and she stays with you. So this is preschool graduation, and all the children are lined up, and they're singing a song that they have practiced and rehearsed until they are sick of singing the song. How do I know they're sick of singing the song? Look at the boys here. Look at these 3 boys. Ah, do we have to sing this song again? But they stand and they sing the song because they have the ability to learn it, they have the ability to remember it, they have the ability to retrieve it from their memory, they have the ability to stand still, More brain cells fire to stand still than to move. The human body and the human brain wants to keep moving. That is how we survive, not by sitting still, but by moving. And children have to learn to stay still. This picture was given to me by the mother of a girl I consulted with. And this little girl was very pleasant and very nice, but she couldn't keep track of her crayons, would lose them. She couldn't sit in the circle without laying down and falling all over the place. And this mother, when I asked for a picture of her child, gave me this picture. I asked parents, show me a picture of your child. I want to see what their faces look like when they hand me that picture. Because I can't go out in the world and see their children. I can't follow their children around for a week or two, which would be a good thing for me to do. I have to rely on them to come to me to give me a history about the child. And this is the picture she gave me, so I asked her which one of these girls, and notice they're all blonde, blue-eyed children. It's in Salt Lake City, a lot of the population, the particular Mormon population, comes from the Scandinavian countries, believe it or not. And so here are all the children lined up, and I asked the mother to show me her daughter, and her mother replied, she is not in that picture. So why does she show me this picture, I wonder? And I came to appreciate this mother's sense of humor, which is very important as a parent or as a professional, to be able to laugh sometimes, even though it's a very serious situation. And she took out a second picture, and she said, I showed you that picture so you could see where my daughter was, and I thought her daughter was in timeout. I thought her daughter perhaps had done something wrong, some great crime or transgression. Here's her daughter, way on the top of the hill. And the hill was alongside this backyard where they were graduating from, and this little girl had, and before you knew it, she was up on the top of the hill. No kidding. And the mother had the sense of humor to take a picture of her before they went to get her, and no one had seen her escape. She just snuck away. So this is the little girl or little boy we talk about today. This is the child whose great crime is their delay in maturation in their abilities to govern and regulate and control themselves. See, we've created crimes out of children's developmental differences. We've created disorders, conditions. This is a developmental difference. This is a child who is struggling neurologically to develop the kind of self-control other children of her age possess. That is her great crime. And so at this age, at 5, we talk about this child as being immature. It doesn't sound so bad, does it? But what will her kindergarten teacher say about her? Her kindergarten teacher will probably say to the mother, your child is hyperactive. That sounds like a much more dire and severe word. And then the kindergarten teacher will tell the mother, I've tried to get her to sit still. I've punished her. I've pushed her down. I've tried to get her, which is what we do to her. And then the teacher says, perhaps she needs something special, maybe a special class. Again, there's nothing wrong with this child at this point other than her failure to develop the self-control needed to fit into the group. And now she progresses to first grade, and the first grade teacher has a different word for her. First grade teacher's word is ADD. I think your child has ADD or ADHD, which again is a label that is used to describe a pattern of behavior. It's just a label used to describe a pattern of behavior, but that pattern of behavior does begin to cause the child impairment. The child is not functioning well within the group. And in the States, at least, that child is quickly evaluated and in increasing numbers placed on medication. And I have no stock in any drug company. My agenda is not for your children to be placed on medicine. I noticed that Eli Lilly has graciously contributed some money to this conference. They are a drug company that manufactures one of the drugs used to treat this condition, but that's not the goal of this conference. In fact, I have very little discussion today about medicine unless it's something you will ask about. I'm really not interested in talking about medicine. And part of the reason I'm not as interested in talking about medicine, one, there are very few physicians. Are there any physicians here? Any MDs? So no hands come up. There's a physician. So there are very few physicians. So you have questions about medicine, specific medicine questions. That's one. The other reason I'm not as interested in talking about medicine is because we very well demonstrated that pills will not substitute for skills. We've demonstrated that while medicine gives us good symptom relief for all kinds of problems, when it comes to ADHD, the medicine alone is not sufficient to change the outcome of these children. And when we talk about the significant life problems these children have, not all of them, but a significant percentage of them, it doesn't matter whether they took medicine in their childhood years. The rates of substance problems, of depression, of work problems, of health problems, of relationship problems do not seem to be reduced in the adult years because you took medicine as a child. And that's the most current research. So medicine is a good symptom reliever, but may not necessarily give us the hope that we had 20 years ago when we said to parents, if you have your child take this medicine, then when they grow up, they will be better. The medicine may insulate and protect you today. It may decrease the likelihood your teacher will yell at you today, or your mother will be angry with you today. But it doesn't seem to be sufficient in and of itself in changing the life course of these children. And what we will talk about in part today are the group of children that we followed who, despite their adversity, despite having this diagnosis, manage as adults to do fine. And it isn't because they outgrow this quality. It is because they learn to live with it. It is because they learn to take advantage and harness whatever strengths and assets and abilities they possess. It is because they learn to create a life for themselves in which having this disorder doesn't cause them to have serious impairment. So the true solution lies not in fixing symptoms, but in building assets and strengths. The outcome we are seeking in helping children with all developmental problems have normal adulthood lies in helping harness their strengths, not necessarily fix their weaknesses. Does that make sense to everyone? We'll talk about that a little bit more. Okay. So what do I want to do today? We have 3 goals. First, we're going to talk about impairment, and I'm going to try and do that before 10:30. And that top, for those of you who don't read English, the top line reads, I'm going to introduce the concept of impairment as the true target of diagnosis and treatment of any condition. And for those of you that are in a position to diagnose, I can tell you that the current research that will look at, that's looking at the diagnostic manuals for 5 years from now is looking primarily at impairment, not at symptoms. By the way, I see some of you are taking pictures of the slides. That's fine. But if you want a copy of these slides in English, I will make them available to the charity, and the charity can make them available to you through their website or however they do it. It's easier to just send one copy to them, and they'll make it available to you. The second line reads that I'm going to talk about the role of resilience or protective factors in treating childhood disorders. When we take a group of children with ADHD and we ask not about their symptoms, but we ask about how they are doing in everyday life, we find some are doing well and some are doing very poorly. The rest are in the middle. And what we discover is that it is strengths or protective factors, I use the term resilience, that explains this difference in outcome. Does everybody understand that? That the difference is not explained necessarily by intelligence level, is not necessarily explained well by whether they take medicine or not. In fact, in one very large study in the United States, 5 years after starting medicine, a group of children who were taking medicine were not behaving any better than a group of children with ADHD who had never taken medicine. Again, I'm not against medication, but we're recognizing that life is a lot more complicated than just taking a pill. And if you want to help these children, there's much more to be done than just giving them a pill every morning. And finally, the last line reads that I'm going to talk about ADHD. What is the current definition? What is the current cause? How do we evaluate it? And how do we treat it? If we cover all of this, we will probably be able to go out dancing at about midnight tonight. So we probably are going to have to take some shortcuts as we go through this, and I'll make some decisions about doing that. But I will make all of these slides available, so even the things I don't talk about, the slides will be in here. So let's talk about impairment, and let's define some terms first. Now again, why am I talking about impairment? Because impairment is the true target of our evaluation. Because impairment is the true target of our treatment. That when we treat ADHD, we're not treating the symptoms, we're not treating the diagnosis, we're treating the problems that the symptoms and diagnosis cause. The target of treatment is reducing impairment. So what are symptoms? Symptoms are those behaviors that we use to make the diagnosis, such as, for ADHD, he doesn't sit still, doesn't pay attention. There are 18 symptoms of ADHD, 9 of them related to attention span, 9 related to hyperactive, impulsive behavior. And not all of those symptoms are equal. So it is the case that some of those symptoms are much more powerful in causing children problems than others. It is the case that some of those symptoms are much more predictive in whether or not you should get a diagnosis. We will talk about that. But in the current diagnostic system, each symptom seems to be equal, and so children don't have to have all symptoms, they have to have some symptoms. And not every child who gets the diagnosis has exactly the same set of symptoms, because those of you who diagnose and use the ICD or the DSM know you have to have so many symptoms from a list, but the list has many more symptoms than you need. In the DSM you need 6, but there are 9 on the list. So as long as the child has 6 of those symptoms, they don't have to have the same 6 symptoms as the next child. So that's symptoms. The next one is severity. How severe is the symptom? So let's pick a symptom. Hyperactivity. Everybody understands that symptom? How much you move around when I don't want you to move around. It's not how much you move around on the playground. Because on the playground, usually it's hard to find the hyperactive child. all children move around a lot on the playground. So you can't find them necessarily by how much they move until you say, don't move. And when you say don't move, those children who move first probably have problems controlling themselves. So that's the symptom. The severity would be, I asked the mother, how hyperactive is your child? A little bit, a moderate amount, or a lot? Now the situation. Let's pick a situation. Sitting at the dinner table. How much does your child move around at the dinner table? And finally, before we come to impairment, adaptive functioning. What does that mean? Adaptive functioning equates to knowing how to do things. Does the child know how to sit still? Does the child know how to use a fork to eat, despite the fact that he's using his hands and standing up at the table? So adaptive functioning is the knowledge of how to do things. It doesn't necessarily mean you will do it. And finally, impairment. Impairment is the functional outcome caused by the symptom. The symptom I'm using as an example is hyperactivity. This mother tells me her child is very hyperactive. I ask her, how is the child at the dinner table? She tells me he has a lot of problems. I ask adaptively, does he know how to use a fork and spoon? Now, if the mother tells me no, now that may be a different problem. But in this case, the mother says, oh yes, he knows how. He knows how to eat properly. He doesn't, but he knows how. And finally, we come to impairment. I ask this mother, how much trouble is this child having because he doesn't sit or eat at the dinner table? Is he malnourished? Is he getting enough to eat? That's the measure of impairment. And if we use that example, most children with ADHD are not impaired because they don't sit still through a meal. They manage to find enough food to eat. It is their parents who are impaired because the child won't sit through the meal. Everybody have that? So impairment varies. What if the symptom is hyperactivity, but the situation is the classroom? And the adaptive functioning is reading. And I ask the teacher, does the child know how to read? And the teacher says yes. He's passed his reading exam. And now I ask about impairment. Is he getting his work done? And the teacher tells me no. Now we have a more serious impairment from the same symptom, hyperactivity. And in fact, in the early school years, most children with ADHD achieve academic skills at a rate that's similar to normal children. But by later school years, they tend to fall behind 1 or 2 years because they don't do the work. Does everybody understand that? That's not a learning disability. That's, I'm not making progress, I'm impaired because I don't sit still even though I know how to do the work. The child with a learning disability doesn't have the adaptive functioning. He doesn't know how to read. The child with intellectual handicap doesn't have the adaptive functioning. He doesn't know how to use a fork and a spoon at the dinner table. Does everybody understand that? And that's why the true target for ADHD is impairment. Whereas for autism, the true target may start with adaptive functioning. That is, the autistic child doesn't know how to socialize, doesn't know how to not be so rigid about things, doesn't know how to engage in a conversation, and therefore they have impairment in the social world. But to help them, I have to teach them the adaptive function. To help the child with ADHD, I have to find strategies to get them to do what they know. Again, I will tell you that children with ADHD know what to do. They just don't always know when to do it. They typically know how to do everything, but they have poor timing. Is now the time I'm supposed to do it. Why do I take time to tell you about impairment? Again, because all of our research is demonstrating that the true target of our evaluation is not the diagnosis, but the measurement of impairment. That the true target of our medical interventions, of our use of medications, that the true target of our psychological or physiotherapy or speech therapy interventions is reducing impairment when it comes to ADHD. Now, sometimes children with ADHD have other problems. And if they have speech and language problems, then we have to improve their adaptive functioning because they don't know how to communicate. But if we look at a child who has just ADHD, which typically is a small percentage, most children with ADHD have other conditions, other problems. But if we take a group of children who have just ADHD, they know what to do. They have the adaptive functioning, but they don't do what they know. And if you stay in the field, you will hear 5 years from now that the process of diagnosis starts by measuring impairment. And the diagnosis before 1987 for ADHD didn't even require impairment. You made the diagnosis, and then you asked, does the person have any impairment? And you could say they have no impairment, but you still gave them the diagnosis. This was very confusing for people. It led people to believe that you could have ADHD, and if you don't have any impairment, then maybe it's a good thing to have ADHD. Maybe it makes you a good pilot, or a good stockbroker, or a good hunter. Although I'm not going hunting with someone who looks this way and shoots that way. There's no reason to believe that it's going to make you an asset. And since 1987, we've changed slowly. We more and more focus on impairment. Again, I'm not suggesting that people with ADHD can't be successful. I'm suggesting that if they are successful, it's because they've learned to harness their strengths and abilities. They've learned to live with an adversity that requires them to figure out how to be successful. It's not as easy for them. But these are conditions. ADHD is a psychiatric condition. We give the diagnosis because someone has problems. If you tell me I'm very hyperactive, I'm very inattentive, I'm very impulsive, but my life is great, I'm not having any problems, I'm not giving you a diagnosis. The diagnosis requires significant impairment. Okay? So as we go through the day, the focus is on impairment, not so much on symptoms. So this slide reads, impairment represents the functional limitations imposed by the interactions of symptoms and their severity, situations, and adaptive skill. So what if you had a mother who made dinner a lot of fun? What if you had a mother who put 3 covered bowls on the table and said, spin the spinner, and under one of those covered bowls is your favorite dinner. Let's see if you're going to win your favorite dinner tonight. We create novelty. What do we find for children with ADHD? Ooh, they sit longer. When you make the task interesting, you get their attention. They like novelty. If you make the payoff valuable, they like novelty, and they function better. So there are things that one mother might do that might make the dinner time a lot easier than for another. In the United States, we have a reality show called Trading Families. That doesn't run here, probably. So they take the mother from one family, and they find the most disturbed families they can think of. They take the mother from one family and they put her in another family. And they take the mother from this family and they put her in a different family. And it's always very interesting to see how a family that was very dysfunctional with one mother, when this new mother comes in, she does things differently. And this family is a whole lot better. And the family that was doing pretty well gets the dysfunctional mother, and in a short time, their family's in chaos. You know? That's how critical it is when you look at the impact of, say, a mother might have on how the family functions. Could be a father, too. Could be a sibling. But the situation may vary, and that may vary the level of impairment. So that's impairment. Now let's start. I'm going to use every minute I have till 10:30. We talk about resilience. So I know a young man, and if we had time and simultaneous, we have simultaneous translation, but if I had the ability to translate on the screen with closed caption, I'd show you some of this video. I knew this boy when he was 13. He came to see me because his parents were concerned he didn't do his schoolwork. He didn't sit still. And he didn't pay attention. And he was very nice. He was fairly intelligent. He had no learning disabilities. And he clearly had the symptoms and the impairment to justify a diagnosis of ADHD. The diagnosis is given as a way of acknowledging that this person needs our help. That's why we give diagnoses, to acknowledge that we need help. This is not medicine. These diagnoses are developmental. We give the diagnosis to qualify someone for assistance. And he took some medicine for a while. He didn't really like it. He told me, and I'm going to show you some pictures later of children drawn for me when they take their medicine. But he told me he wasn't a lot of fun when he took his medicine. He didn't like it, even though he got more schoolwork done. So he didn't want to take the medicine. And he would come to see me every once in a while for counseling, and we would talk. And I liked this young man, but I didn't have to live with him. And his parents were very frustrated. And eventually he gets to high school. He's not going to graduate. He has a girlfriend, and she becomes pregnant, which happens with ADHD. And his parents suggest to him that he leave school. They didn't throw him out. They supported him. They helped him. They assisted him in giving he and the girlfriend a place to live. And he started working. He started working making minimum wage. Is that a term you have here? Minimum wage. And then his baby was born. First child was born. And he tells me how he held this child in his arms, and he realized that life was no longer just about him, but now he had a child that he had to support and a wife. And he decides to go back to school. And it takes him a while, and eventually his wife goes to register him because he kept forgetting to go do it. And he starts to go to school at night. And he discovers that he actually can be good at school if he devotes himself to it, if he makes himself do it. His parents realize he's being successful, and so they suggest that he stop working and go to school full-time, which he does. He eventually graduates from college. He calls me up and tells me he's decided he wants to be a psychologist. And I told him he didn't have to do that for me, but he really wanted to be a psychologist, and we talked about what kind of psychologist, and he applied to graduate school. And he actually had been a very good student in college. And he got in a number of places, but where he really wanted to go was Harvard. And he got into Harvard. And he went to Harvard, and he was a big star in Harvard. His professors loved him. He took his medication. That was the only thing he did. He said, if I didn't take my medicine, I had a hard time sitting through class. But he had to work harder than everybody else. After a couple of years at Harvard, he asked if he could come back and do a residency with me. And I said, sure. And he moved his family back. He hadn't graduated yet, but he moved his family back. And after a few weeks, he called me up, and he told me that he had bad news. He had to move back to Harvard because he'd forgotten to take some classes. This is a true story. And his professor said, you have to come back, take them here. You can't take them anyplace else. He moved back to Harvard. He's got a wife who is a saint. Now he has 2 children. And, well, he graduates from Harvard. And when he told me he wanted to come back the next year, I said, talk to your professors. And they said, no, you stay here. And he has done brain research. And he is now he's a member of the faculty at Harvard in psychology and astrophysics, of all things. And he now sits on the editorial board for my journal. And he's very good at reviewing papers. His name is Todd Rose. So he still has ADHD, and he still takes medicine. And he still carries around an electronic organizer with an alarm set all over the place, reminding him what to do. Otherwise, he forgets. And when he met me in Boston a couple of months ago for lunch, of course he was a half hour late. He has ADHD, you know. And yet, here is this man who is successful, and the question is, how? What factors makes that difference? And that's what resilience is all about. We'll define it when we come back after the break. It is the ability to continue functioning well, despite the fact that you face adversity. It is a process that focuses on harnessing your strengths and abilities to deal with whatever problems life brings you. It is not recovery. It's not where you go down and then come back. It is you continue functioning even though life is challenging, even though life is difficult. And the qualities that predict this are universal. It doesn't matter if you have autism or ADHD. It doesn't matter if you have a medical problem or you live in an abusive home or you come from a community where you've been maltreated. It doesn't make a difference. These qualities are universal, and they're also ordinary magic. Ordinary magic meaning what? You're not so special. They're the qualities that children get to develop when they live normal lives. Parents who appreciate and support them. A family that takes care and protects them. A school setting in which they can be reasonably successful. The ability to learn to problem solve. To develop self-discipline and self-control. To have what we call in our work an island of competence. To possess an ability that you know makes you special, that you take with you out into the community. These are not mysterious. These are not magical. And yet we have demonstrated time and time again that when children have the opportunity to develop and harness these strengths, they can cope with nearly any adversity. I know a boy at one of Alistair's facilities who shouldn't cope, given the challenges that this boy faces. And yet he has the temperament that engages you, Aunt Flora, and you're drawn to him. And he has learned to harness his particular strengths to make a pretty good life for himself, despite all the challenges and the medical problems that he faces. So, why do I take the time to do this? Because here again, it is important for you to understand that it's not just about diagnosing symptoms and making diagnostic pronouncements. An evaluation requires that we equally, if not to a greater degree, appreciate and understand every child's strengths and assets if we're going to help them. And that's true for any condition, and we now know it's particularly true for ADHD. So, when we come back after this break, we'll talk a little more about resilience, and then we will begin talking about, so what is ADHD, and why should we call it something? Why don't we just say the child is a bit inattentive or a bit restless? Why give the diagnosis, and what does the diagnosis mean? Okay, so we see you half hour? Half hour. Okay?